Hello, good afternoon, everyone on the East Coast, morning, folks, for everybody not in this time zone. Hope you're having a good Friday. We look forward to this Friday's discussion on, on surprise medical billing. So we have a great team of experts as usual with us, and all we're led by our very own Mia Keys. She's joined by her California colleague from the California Medical Association, Elizabeth McNeil. We have a patient advocate, Jill Cisco, and of course, my boss, Dr. Gary Puckrin. And so without further ado, I'll go ahead and turn it over to Mia Keys.
Welcome back, everyone. Thanks again for tuning in for another week of our discussion with NMQF and all of our amazing partners in the field. And as Brendan said, I'm Mia Keys. I'm with the American Medical Association. And as always, I'm very proud to be speaking to you all today in conversation. And today's conversation is particularly concerning, right? Especially because it was with us, the phenomenon of surprise billing was with us prior to COVID. And now since COVID, it's especially of earnest concern. And so today we're going to hear from, as Brendan mentioned, our colleagues and our friends and people who themselves are patients, as well as patient advocates who have experienced the tenuous nature of billing and certainly surprise billing. So what I'm going to do is, for the moment, I'm going to just ask that we just have a brief overview from our panelists on what surprise billing actually is. And of course, we know what it is, but I want us to really ground ourselves in the same understanding. And so for the time being, I'm going to ask Jill to tell us briefly about her story and tell us about what surprise billing is. And then once Elizabeth joins us, then we'll also be able to hear from her directly. So Jill, why don't you go ahead and take it over?
Well, first of all, I want to thank you for having me here today. I am a patient advocate in the acromegaly world. Acromegaly is a rare and chronic disease typically caused by a tumor of the pituitary that produces excessive amounts of growth hormones and leads to overgrowth of the extremities such as the hands and feet, facial shape changes, and not to minimize, it also causes our organs to grow. Long-term disease can lead to serious damage to vital systems and organs, such as the heart. And this condition affects every organ, joint, muscle. It literally impacts the entire body. This condition hits us from all sides and affects us hormonally, physically, mentally, and financially. So with that, you can understand that we go to the doctor more than what the average person does. Surprise medical bills impact our community just like it would most people, in that it can be a shock to receive a high medical bill and learn that it's not covered by your health insurance. The way it is scarier for our community is that we have more medical encounters, blood work, visits to doctors, than the average person, which increases the likelihood that we will receive a surprise medical bill. Further, because our patients often have a complex situation, they are far more likely to head to the emergency room instead of the hospital or an outpatient health center. I've heard many stories of ER visits, blood work, and some testings that insurance companies don't cover. And this is very alarming to me as an advocate within the acromegaly world, that our patients are suffering from this.
Yeah, Jill, thank you so very much for weaving in just an overview of surprise billing, but then also introducing your personal story. And I'm hoping that as we continue our conversation, we'll hear more and more about that from both the patient perspective as well as the patient advocate perspective. So Dr. Puckrin, I want to bring you in on this. You know, you're such a wealth of information in so many different ways. You're like one of the most sagacious men that I know. And so I'm wondering from your perspective, and then also as CEO of NMQF, can you tell us what are your biggest concerns, what are NMQF's biggest concerns around surprise medical billing?
Thank you, Mia. First, I want to say to Jill, several years ago, we actually mapped Agromegaly, and I'd love to at some time have a conversation with you, because we actually put it to a geomap. Anyway, on the issue of surprise medical billing. Surprise medical billing is a bill that a patient receives from an out-of-network provider that treated them. And it could be that they were in an in-network facility. So for those who don't know, the way many insurance policy works, you have in-network providers who are less expensive than when you go out of network. And so you may have gone to an emergency room or had an unscheduled care and it was provided by an out-of-network provider. And then the patient receives a bill either from the hospital or the provider that is out of network. And it often happens because the insurance company has decided not to pay the bill because it was out of network. And so that's what the whole term of surprise billing is. The patient is not told at the time of care that the provider is out of network. Often, it's happening in an emergency situation. So you can imagine right now in this COVID world where people are being rushed to the hospital and they're being treated by someone out of network, and then they're hit with a higher deductible payment because the insurance company has refused to pay for the care. So that's the problem, and the question is, how does that problem get resolved? And I think that's part of what the conversation is about today. But what I would say from a NMQF standpoint, and anybody that knows and works with us, we always think that the purpose of the healthcare system is to reduce the patient's risk. And the system should operate to reduce risk all the time, not part of the time, not half the time, not for particular groups of patients, but whenever you walk into a healthcare facility, its job is to reduce your risk. And certainly no patient goes into a healthcare system believing that the system is going to elevate their risk for outcome. Unfortunately, we have this bizarre reimbursement system in our healthcare system. It really is a patchwork of all kinds of formulas that got created all over the place. And so part of the problem stems right down at government, right? So when you look at programs like Medicaid and Medicare, when Medicare first got started, the promise was that it was going to pay the standard rates for care. That's what it said to everybody. Government was going to come in, and there was this great fear that government wouldn't pay the market rate for care, and they promised us to die and that they were going to pay market rate. Now they're not paying market rate. And particularly, certainly it's worse in the Medicaid program than it is in the Medicare program, but the Medicare program is not paying market rate. So what's happening is that commercial insurance is making up the gap. So those who are providing care, be it a hospital or a physician, right, if they take Medicare and Medicaid patients, they know they're going to get paid less than what they would get from a commercial insurance. And so the way that the difference is being made up is by the commercial insurers paying a little bit more to cover the Medicaid and Medicare program. That's literally what's going on. So now government wants to come in, which is sort of the worst thing you want in your life, is government to come in and set prices. And so what the conversation is that government is not coming in to set prices in the Medicare program, because in the Medicare program, every Medicare beneficiary, for good or ill, and we can take a moment to talk about that, has a 20% copay. Whether they have the ability to pay or not, it's 20%, right? And so there's no surprise billing, you got 20%. So what government wants to do is come in and set prices for commercial insurance, right? And everybody should say, oh my God, no, we don't want government setting prices, any of the stakeholders, because once they put their nose under the tent, they are going to be setting prices all over the place. The real point is, and what we should be looking for, I would argue, is to make sure that we have competition in the market. And that's what government really should be doing, is making sure that there's competition, and competition, as in the rest of our market, would take care of the price of things, as opposed to having bureaucrats sitting around trying to calculate what a price should be, because it's always going to be god-awful and it's always going to be complicated and a mess. What's worse here is that when government comes in to set the price, it's going to set it, no doubt, lower than market rate, and then the Medicare and Medicaid program are going to be affected because the extra payments that the commercial insurers made to support the Medicare and Medicaid program are now going to go away. And so what's going to end up happening all over the place is that rather than looking at managing patient risk, everybody's going to be managing financial risk. And the minute they start managing financial risk, the patients are in trouble, right? Because that becomes the objective of the system, is to manage financial risk. And what we don't want is healthcare systems managing financial risk. We want them to manage patient risk. And so that's what, in our view, is going on with surprise billing.
Dr. Pucker, I think on that last note, I want to do two things. One, I foremost want to welcome Liz to the virtual room. Welcome, welcome. It's quite a morning.
Thank you. I'm so sorry about the time mix-up.
It's all to the good. I'm so glad it worked out that you're here. I want to bring you into the conversation, Liz, and I'm going to do so, but I want to ask Jill to pick up with that last piece that Dr. Pucker was talking about. So just to summarize, because you gave us so many jewels there, you were really talking about not just accessibility with respect to healthcare, but then you're also talking about affordability, right? So you talked about accessibility and patient risk. You talked about affordability and financial risk. And financial risk often leads to risks with respect to patients. And so, Jill, I was wondering if you can just tell us a bit more, if you don't mind, about what it feels like as a family to receive a surprise bill and how that really impacts your ability to access your care. And then I'm going to go to Liz and talk about some solutions on the federal front.
Well, you know, so many patients try to do what is right in regards to their health insurance. They try to go to in-network, facilities. How are they supposed to know if someone within that facility is not within network? It's just shocking to me that insurance can present a bill to you for something that you weren't even aware of that you would receive to begin with. With the cost of our health care already, being hit with these extra expenses can be devastating for a family. And unfortunately for people within my community, they have to go to certain facilities in order to receive good treatment. Because of acromegaly being a rare condition. You have to see physicians that truly understand and know about the condition in order to help improve the quality of life of patients. So it's very shocking to me. And we live in one of the best countries in the world and I just can't understand why this is still happening. In my personal opinion, human life is more important than the dollar. And we have a ways to go here in the US in order to make sure that patients always come first.
We absolutely have a ways to go, for sure. And with respect to that, in terms of where we are compared to what can potentially come, I'm wondering, Liz, if you can talk to us a little bit about, what are those federal legislative potential solutions? I know Dr. Pucker alluded to some of them earlier. Can you talk to us about, what are some solutions that are popping up on the congressional front? But then also, being that you're from the California Medical Association, what's happening in Cali? I mean, Cali is consistently leading the country oftentimes with respect to health innovations and health interventions. And so I'm wondering if it's the same case locally with respect to surprise billing.
Great. Well, thank you, and hello, everyone. I just wanted to say too, before I get into the solutions, just mentioning the physician perspective before we jump into that too, because Jill's absolutely right. You know, that the healthcare system is already difficult enough to navigate if you're a patient, and so there isn't a physician organization, I don't think, in this country, certainly the California Medical Association, the AMA, and others that support what's going on in this world right now of these surprise bills. And we don't condone this act. That it's just been a handful of physicians that have sent some of these very big, really out of whack surprise bills to patients that have been inappropriate. And so we don't support that, and we do want to see a solution. But I think where we're coming from is we want to make sure that it's balanced with the insurance companies, because as patients know, that in many communities in this country, we have access to care problems, and physician supply is a real problem. If you're in a rural area, if you're in a minority community, the disparities are great. The access to care is very difficult. So we have to make sure that we protect access to physicians when we craft a solution. And so that's been one of our most important things. You know, patients are getting surprise bills more and more, and it started to happen because the insurance companies have been dropping physicians from their networks, and their networks have been shrinking. And so patients think they sign up with a plan, and they think there's this list of doctors in the plan, but when they go to actually find one, those doctors aren't in the plan. And insurance companies in particular have been dropping specialties like anesthesia, surgeons, radiology, pathologists. Those are the physicians that are behind the ER, backing up the emergency room that you don't see. And so when you go into the emergency room, many of those physicians have wanted contracts with those insurers, had contracts with insurers for 20, 30 years, but those contracts are being dropped. And so they are in a terrible position that, yes, they are there to save your life, but the insurance company dropped the contract, they're not getting paid. So some of them are forced to send a bill to a patient. And, you know, for the most part, they are reasonable and based on what's been charged and paid in the marketplace. But there have been a handful of bad actors, and we have to stop that from happening. So in Congress, Congress picked up on this, that patients are very upset about this. We are too as physicians, and they are trying to address the problem. Many states have adopted their own solutions, and Congress started to look at some of those solutions. I would say the law that passed in New York is probably the gold standard of the most balanced law in the country that has protected access to care, but also incentivized both physicians to contract and incentivized insurers to contract so patients can find a doctor and they're in network. And in California, unfortunately, while I think we have led the way on some things in healthcare, we probably, unfortunately, have the worst law in the country on surprise billing. And Congress did look at our law. And so what Congress, and I will get into our California approach in a minute, but Congress, the House and the Senate, several of their committees have passed bills. And basically what they do is they set a payment rate in the law. And most of them, except for the Ways and Means Committee, have set a rate at a median in-network rate, which means it's the contracted rate that's about the middle of what most insurers pay. And they have set that rate in the law. But unfortunately, what happened in California when they did that here, they did not do that same thing in those other states, particularly New York. When they did that in California, the insurer said, oh, look, the legislature just set this low rate in the law, and now we can just drop all our contracts and pay you that low rate. We don't even have to contract with doctors anymore. So the insurers in California started canceling contracts massively with physicians or cutting contracted rates by 30 to 50% in some instances. And so what happened is we had fewer in-network doctors. Patients were going into the ER and they couldn't get access to certain specialists. And in some areas, you know, we were looking through health plan directories in 9 areas of California, there were 0 anesthesiologists who were in network with health plans. So one of the things that we have told Congress that they have to have in this bill, and it is not in this bill, is they have to mandate that the insurance companies have appropriate numbers of doctors in the appropriate specialties that patients need. And as Jill talks about, many patients have very difficult conditions. They need certain types of specialists. Those specialists should be in your plan if you thought they were when you signed up. And so we believe that there should be a mandate that the insurers have to contract with doctors and make sure there are appropriate numbers, particularly in rural and minority communities. And finally, we think that these bills do have a system of what we call dispute resolution. Because if the insurance company pays the doctor and the doctor doesn't agree on the rate, we think there ought to be a balanced dispute resolution system where they can go to arbitration and show the arbiter, what the appropriate rate should be, and the arbiter would make a decision. We don't think that hospitals and physicians should be forced to file lawsuits just to get paid. That increases costs in our healthcare system. So from that standpoint, the congressional bills have set up a process to do that. But I think one thing that's holding up the final solution here is that many, many members of Congress still don't feel really comfortable, with the committee proposals that have been put forward, because they're still worried that what it will do is reduce access to care, because insurance companies will be disincented from contracting and paying appropriate rates. Pretty soon you don't have doctors in certain communities because they can't afford to take care of the patients at those rates, particularly in low-income communities. And so they're worried about whether we will have access to care in the long term. Do you discourage students from even going into medicine? So I think there's this uneasiness that we still haven't quite hit the sweet spot to get the balance that we need to make sure we'll have access to care. And I think that's what's holding up the final solution there. And we're all working to try to get there.
I think you set up the question that I then want to give to Dr. Puckern very well. But before I do that, I want to invite the audience to just give us some of their thoughts. Let us know through this poll that you can answer on your screen. Have you experienced and have you received a surprise bill in the past? And so just let us know how you feel, what your experience has been. I'm going to answer my question now, at least I think so. Let me answer. Okay, we will get those, we'll get those to you. Oh, it looks as if we're unable to vote here, Keika. We'll get that fixed, and when it pops back up, we'll go ahead and we want to know your answers for sure. But Dr. Puckern, so what Liz was just explaining right now really, I think, strikes a chord. So you brought up words like resolution, balance, compromise, right? I'm wondering, what does it mean for there to be a compromised solution such that insurers are able to offer potential patients what they need, such that doctors themselves are not being shorted with respect to reimbursement, but then also patients are accessing who they need with respect to their care needs, right? So why is the solution based on compromise so significant with respect to ending surprise medical billing?
I think compromise is the real solution here. The priority ought to be first off the patient. Everybody in the system has to understand that their priority is the patient, and we can't have a solution that puts patients at risk, either directly or indirectly. That's just not appropriate. And so I think if government wanted to play mediator role, which is probably as far down the road as I think they should go, then setting up a system where they can negotiate out is the proper way to get things resolved. What I would be against, quite honestly, is government setting prices. I just think that in any other part of our economy, the very notion of government setting prices would be abhorrent. And just thinking about government coming outside of a government program, this is not Medicare and Medicaid we're talking about, we're talking commercial insurance, to come out of there to say that it's going to decide what is the appropriate price or median price or whatever not to say, because it always has residual impact. It always torques the system in some way. I think really in this particular instance, the solution is through some system of negotiations, and obviously we would encourage plans to make sure that their networks are vibrant and can serve the needs of their members, and being careful that they're not narrowing the marketplace. And if I would add one other point to it, is that this is also sort of a function of employer-based healthcare, right? Because employer-based healthcare is really about wages, right? It's really about what employers are willing to pay by way of wages to their employees. What was nice, I thought, about the Affordable Care Act is that it made the insurer consumer-facing. And so if the consumer had mobility, that would create the competition that in itself would start to resolve things like surprise billing. Because if you've got to recruit your patients every year, like the cable company has to recruit and compete, all of a sudden you don't want them to get a surprise bill. You would figure out how to collaborate with everyone so that doesn't occur. But one of the impacts of the employer-based system is that the client is actually the employer, because what the insurer is trying to do is help the employer manage wages. And so these are the kinds of things that result from that.
Yeah, I think you brought up a really significant point. It looks like Elizabeth also wants to chime in.
Yeah, I just wanted to say something. I think that Dr. Puckrin is absolutely correct about that. And one of the great things about the New York system and what's in a lot of the congressional bills is something called baseball arbitration. We don't have baseball season going on right now, but baseball arbitration. And what has happened in that is they ban balance billing, ban surprise billing. We are all for that. Let's stop it. And then you say, okay, you go to a baseball arbitration system where the insurance company puts their rate on the table that they think is a fair rate. And the doctor says, well, I think this was a fair rate for the 3-hour surgery that I did. And they submit those rates to the arbiter, and the arbiter picks one or the other. And the rates and that forces everybody to say, oh, I better put a reasonable rate on the table. The doctor can't charge too much money, and the insurance company can't undercut things too much. So they basically come in at where the market is, and then the arbiter picks one or the other. And in New York, the decisions have been pretty evenly decided, 50% for the doctor, 50% for the insurance companies. And so it's been a fair system, and it seems, and it's very quick, it's cost effective, it doesn't cost money. I think it's a few $100s to go to arbitration for the physician. There's no cost to the patient. So it's so that sort of a system I think the doctor's talking about is something that would be fair, protect the patients, it takes them out of it. And then if we can just get to making sure the insurance companies have adequate networks of doctors so that you have doctors there for access. And then we have to deal with the high deductibles. A lot of patients get bills from physicians for the deductibles. I don't know how physicians got in the middle of this. It should be the insurance company sending the patient that deductible bill, but a lot of patients are surprised by those high deductibles and they think it's a surprise bill, but it was actually the plan they bought. But we need to address those high deductibles because they're really making care unaffordable for patients, and they don't even go to get care because they're afraid of that high deductible. So, but anyway, back to that negotiation, I think that baseball arbitration system, it's been very fair.
So I want to just go back to the poll question and just get a proper polling from that, audience and panelists. Have you ever received a surprise bill? Yes or no, or you're not sure? Maybe it could have been a high deductible or rather a deductible in general, as opposed to a surprise bill. So we'll go ahead and get those answers recorded. Joe, I wanted to bring you in, and so Dr. Puckern's offered what a compromise-related bill can look like. Elizabeth has given us some perspective as well. From a patient advocate perspective, what entails the answer or answers, potential answers and solutions for surprise billing?
Well, I think the simple answer, of course, is that a surprise medical billing should no longer exist. But of course, the devil is in the details of how you do that. I do believe that from a patient perspective, that there should be compromise. I think that it can't be lopsided one way or the other, because that in the end will also involve the patient, and it sticks us with billings that we shouldn't get to begin with. I think that there should be an incentive there for both parties to submit, pretty similar bills anyway to each other, and hopefully a compromise will work, and that both sides will negotiate. I worry personally that some of the federal policies that have been advanced so far are too lopsided in the favor of insurance companies. The last several years, I'm hearing more and more from our patient community that they're being affected by some of these policies. And, I want to thank organizations like yourself that are going to bat to try to help protect patients.
Yeah, I think, you all are bringing up some critical issues for sure. And I think a large part of it has to do, in terms of on the patient end, a lot of times patients are not aware, or the families are not aware that they are going to receive some kind of bill. That is literally the essence of a surprise bill, right? But then on the other hand, with respect to providers, and providers might be surprised that when they do submit the rates that Elizabeth was talking about, that those rates are then not met. So I'm wondering, and this is a question from the audience, in what ways, health, especially new practitioners, are not necessarily trained in medical school, in nursing school, in dental school, so on and so forth, about how to negotiate rates, about where to set the standard with respect to bills for their services. What needs to happen in order to ensure that practitioners are well educated, and with respect to medical billing? And this is for anyone to answer.
Let me take that, Mia.
Please.
I'll start in, Mia. I think the biggest issue is not so much education. The insurance companies in this country are very powerful. There's only a handful of them. And most of them offer take it or leave it rates. They say, here's our rate, you take it or leave it. There's very little negotiation that goes on. And most practices in this country, while there are some large physician groups around the country, still most physicians are in small, little independent practices, and they just don't have the power to negotiate, market power to negotiate higher rates with the insurance companies. So they take these rates, so they take rates that are in the marketplace. But what's happened is the insurance companies have just dropped them from contracts, so they can't even get a contract because the insurance company thinks they save money by not having to contract with people, and then they don't have to pay them, right, when they provide care. And they don't have to pay the deductibles, and when the patient's out of network, the patient pays more out of pocket. So the insurance company has used this as a scheme. So I think it comes back to reining in some of this market power of the insurance industry to bring more balance into the marketplace. And that's what's really needed. And I think if we said to the insurers, you must have contracts with physicians so that every patient that signed up with you has appropriate access to care in geography and time and distance and all the appropriate specialties, that's where I think you will get you will fix that problem and get more access.
So I wonder, does anyone else have anything to offer for that question? Please,
Well,
go ahead, Jill.
Can I mention that in my state, I have a gold policy on the ACA, and with my policy, if I go out of network, my insurance only covers 50%, and there's no cap. So it would actually be better for my insurance if I literally went out of network to every single one, but it makes it so unaffordable that I know personally, I try to make sure that every single one of my physicians are in network, you know, because my healthcare costs are already so high. But for instance, if I were to need another brain surgery regarding my condition, there's no one qualified within my network to do it. And so if I were to have to travel back to where I had my original surgery, I would be hit with 50% of that surgery with no cap. And that is just shocking to me as a patient. As someone that's tried to do everything right, you know, their entire life, that I'm in this situation.
And Jill, if you don't mind me asking, how many surgeries have you had for agromegaly?
Well, I've had one surgery to remove the actual tumor, but I've probably had, since that time, between 10 and 15 other surgeries because of this condition.
Yeah, and that's just the actual in hospital care. We haven't even talked about outpatient care.
Correct.
Yeah.
I mean, it's a difficult situation to manage, and I was speaking to a patient just yesterday that had to go to a facility, and the doctors were covered, and he thought that his surgery was covered, and he got hit with a $68,000 bill.
Wow.
Who can afford that?
Who can afford that? And I think that really dovetails well into, you know, us putting ourselves into patient and patient advocates' shoes, especially during COVID-19, right? During this pandemic, aside from the devastating impact that it has on people from a physical standpoint, right? The costs for care are astronomical. I've certainly been reading reports and articles about patients and their families being hit with bills also in the hundreds of thousands of dollars, right? But you know, the cost of a life is almost, I mean, what do you do, right? Exactly, what do you do? So I do want to have this conversation about COVID, but I do also want to pull in the polling results, Keiko. So it looks like half and half. Some people, half people for the most part have received, well, about 45% say yes, 44% say no, and then others don't know. And I think that's really quite telling. You know, some of us have been there and some of us don't know exactly what the bill might look like or might entail. So definitely there's a gap in terms of maybe even understanding our insurance or even understanding how to navigate it to get those answers to the questions that we might have about what is covered in our insurance. But especially probably for marginalized and minoritized people and people who are living in rural areas, people with low health literacy rates. So I do want to talk about how the moment of COVID-19 is especially bearing on those patient populations and their families. And so this question is for anyone. You know, COVID has showed us these challenges of what happens especially when hospitals have a sudden drop in revenue because they're not seeing patients at the same rate as before. Because right now, ERs are predominantly empty unless there's, you know, people presenting for care because of COVID. So I want to know, you know, how has this moment impacted people's lives, their ability and willingness to really present for care, not just because of the physical impact of COVID, but the emotional impact as a result of interfacing with the financial hardship.
So what I would do to your question, I would add in the social justice conversation in the middle of this as well, because in the craziness that is America right now, we have this confluence between issues about social justice and COVID and everything else. So the point of the matter is, and I really think that this is an incredibly important metric. So the provisioning of care in the United States is tiered. Even in the Medicare program, where you have social insurance, it's tiered by the ability to pay. We have Medicare Part B and D, which is the prescription drug and the medications that are administered in the physician's office. You have a copay. And if you've got a rare disease or cancer, that co-insurance pay could be 30% of medications that could be really, quite expensive. And so, even in the Medicare program, which everyone is obliged to purchase, we tier that system so that the janitor, the bus driver who worked all of their life had those deductions taken out of their pay when they come to need that service, that program. They find themselves being denied access based on ability to pay. I think, as we're trying to reach the new normal, and that's what the social justice world is pushing us at, as well as what COVID is really demanding of us. COVID is saying it's a collaboration. If you want to stay healthy, you have to collaborate, and part of that collaboration is you got to wear a mask, right? Because that's just how we have to deal with COVID. On the social justice side, we have to come to an agreement that we have to provision care so that everyone has access to the care that they need, that we cannot have a tiered healthcare system, and we can't shift the burden of care off to the patient. The fundamental assumption of health insurance is shared risk. And by changing that formula through patient out of pocket, and all of those kinds of things, really breaks the promise of health insurance, because the core idea is that we share the risk, and in that way we all get access to the care that we need when we need it. And I think the pressure is going to grow on the healthcare system. If you take African Americans, for example, pre-ACA, 48% of African Americans had no health insurance. You're talking about surprise billing. How'd you like to deal with no health insurance, right? And get diabetes or cancer or whatever you got, and you're left with rescue care. The number for Hispanics was 54% of Hispanics had no health care. And there's a sense that was okay. I mean, there are people right now who, in our country, who think that their neighbors shouldn't have health care. They think they should have it, but their neighbors shouldn't have it. So the point I'm making is, and it's really the same answer that comes out of surprise billing and COVID and social justice. We have to make up our minds that our healthcare system has to provide optimal care to everyone that needs it. We can afford to do that, and in doing that, we can build really a fabulous healthcare system. And I think that's the challenge of the moment.
That is absolutely the challenge of the moment, but also I think it's just as easy as you mentioned, right? And this is me inserting myself into the conversation, and then I promise I'm going to go back to what you all are saying. But Dr. Parker, you couldn't have put it any better, right? This moment, meeting this moment, means making the decision that everyone in this country deserves and also has access to optimal care, right? That's what you said, more or less. I think you said optimal care for all. That's equity. That really is the essence of health equity, right? And we've seen, I think the moment of COVID has shown us that the nation and its power structures has the ability to innovate out of crisis. when it decides to. You know, the supermarkets have erected barriers between grocery shoppers and the people who are working there, right? That happened almost overnight. The Whole Foods down my street has now 6-foot delineations within, you know, within the aisles, right? Not that something like that, I mean, it's a small thing, it's a small tweak, but it's an innovation, right? And that level of innovation to scale just shows me that we have the capacity. It's just a matter of will, whether that will is political will, or it's really just a matter of saying that the best, my interest is my neighbor's interest. To your point, Dr. Pucker, my neighbor's interest is mine. It really is a matter of saying we have the tools to innovate. I just don't want to do it when there's no crisis. But I'm going to be quiet and open up the ground because this is you all.
One thing, and then I'm going to be quiet. So tell me, what's the difference between putting your knee on someone's neck and denying someone access to life-saving therapy? I can't figure out the difference between.
There's no difference. There's no difference other than maybe the setting, and that's it.
And
that's it.
And that is the point of the conversation.
Right.
We shouldn't have it in our policing, and we shouldn't have it in our health system.
That's right. Structural inequity and racism is structural inequity and racism through and through. That's it. It doesn't matter where it's at. Jill, Elizabeth, talk to us about your thoughts on the original question, and then also what Dr. Huckman inserted with respect to structural justice, and I'm inserting anti-racism and what that looks like. And I'm also just going to pick up my power cord so my computer doesn't die. But I'm here.
We know that you didn't just faint.
No.
No, you guys are both poetic. I don't know if we can say any more to what both of you just said. We need more justice in our healthcare system, more equity, social justice all the way around, and physicians feel that more than ever that we have got to come up with a better system to protect people, to keep people safe, and to keep people well, and make sure that everyone can get the care that they need in the best way possible. So I can't say it any more poetic than all of you have said it. I will say this, back to your original question, is that many patients are not coming into the ERs right now because of fear of the risk of COVID, social distancing. And I know I hear from many emergency physicians where they have seen people who have had broken legs for over a week, stroke victims that didn't come in right away. So if patients are on this call, I do really encourage you that if you have a serious medical condition, please go get it treated. And the ERs are being very safe right now, and it is important that people do go in and get care if they really need it, because it can get worse and will be more difficult to take care of. And all COVID patients are protected from surprise bills during the pandemic, which is very important. So that's another big issue. And I don't want to take away from the important bigger picture issues there, but I just encourage all patient advocates to perhaps look at the Cassidy-Hassan bill that is in the Senate. It is one of the most balanced, and I think that's what we need. We need balance. We need to protect patients. First job, number one job, protect patients. And number two, get balance in the healthcare system between the insurers and the providers, whether it's physicians and hospitals, so that, you know, neither is charging too much money or making too much money, that there's just balance in the system through an appropriate arbitration, and that those arbiters are looking at rates that are paid in the marketplace, rates that those doctors had with that insurance company for 30 years, you know, those kinds of things. But so there are some solutions, and Cassidy-Hassan bill in the Senate is certainly one of those that strikes that balance and reduces costs and maintains access for patients. But we have big issues going on in this country that are very important, and I think it's time for all of us to rise up to the moment and address them and take what's happening right now to make some change for the better. And I think it's incumbent on all of us, and I know that the CMA absolutely feels that way, and I know we're going to pass some important policing reforms here in the state of California. We're going to outlaw chokeholds and all those kinds of things, and trying to do more to ensure that we have a strong ACA here that is helping low-income patients and communities have access to affordable care.
Thank you for that. Go ahead, Jill.
I need to move to California. But, you know, as a patient, I don't think anyone that I know wants to be sick. They truly, we need to start putting patients to the forefront again. They need to be the focus. You know, in my opinion, you know, patients are grateful for their physicians. They're grateful for the work that they do. And patients don't want their physicians to not be paid. And they believe that they should be paid a fair wage. And it upsets patients just as much as what it upsets the physicians, that this is happening with the insurance industry. And we need to find a way to negotiate to where we do have proper access to all of the doctors that we need to treat us, you know. And it is a travesty that in 2020, we're still having to deal with issues like this, you know. But like I've said, you know, I'm so thankful for those that are fighting for us. And because you know what, we're worth this fight. And you know, I'm grateful for those that have dedicated their lives to treat us. And for that, I say thank you. So.
Yeah, I'm right along with all of you with that. I want to especially talk about in our final moments. You know, so we're on this webinar and we're speaking in English, obviously, right? And not all patients' first language is English, or even their preferred language is English, right? And we're talking in really high jargon terms, but also I think we're having a relatively relatable conversation. But what of those who experience language barriers, in addition to potentially having fear of healthcare systems or mistrust of medical institutions writ large? How is it that we need to be mindful of improving health literacy and overall remedying language barriers with respect to access to care, especially in this COVID moment, for limited English proficient patients specifically, but then overall education for patients with respect to surprise billing? So that was a tiered question, but language access, health literacy, and then overall education for patients irrespective of their preferred tongue.
So one of the things that sort of gets lost in the sauce is that healthcare is the largest employer in the United States. I always laugh because people think it's manufacturing, and they rush around and they want to save manufacturing, and not that it's unimportant, it's important. It faces global competition, etc. But I think the healthcare system is a usually powerful system. It employs people. Some of the stuff that drives me crazy is the largest employer in rural America is often the local hospital, right? And then we want to close it down and wreak havoc on that community. Here's the point. If we get our system properly orientated so that we are focused on the patient, and we're not focused on managing financial risk, but we are focused on the patient will take on a new value in the system. And it doesn't matter whether the patient speaks a foreign language, is gay or lesbian, African American, Hispanic, they become a value in the system, and the system will want to take care of them. And bluntly put, for business reasons, you know, these are the customers that you want to take care of and cherish and show that you are providing value to. if we can figure out how to get our healthcare system oriented around the patient. Like everybody always talks about the patient. I go to a ton of meetings, everybody stands up and says, oh yeah. The patient says, no, you're not. You're thinking about financial risk. You're not thinking about that patient risk. But if we can do that, I think your question gets answered. I think that the moment we do that, the cable companies figure out how to talk to people who speak a different language. I mean, there are lots of businesses in this country that do that at a moment's notice. And so I think that's really the key in the way in which we can get to value here. And things like surprise billing and other things will start to go away because you don't want to treat your customer that way. That's when that's when you disregard your customer. You send them any old thing, right? You say, okay, deal with this one, right? Because you lost sight of who you're actually voting for. So I think that's really the heart of the matter.
Thanks for that, Dr. Pucker. And I really appreciate you bringing up that V word, value, right? We're not just talking about dollars here. We're talking about lives, and we're talking about lives that are differentially valued, right? And whether in the healthcare system, and justice system, education system, and this is our moment of grappling with it. You know, COVID really is the accelerant for a lot of people to pay attention to issues in a way that they hadn't before. You know, and I personally meditate on that a lot. Of course, my day job requires me to attend to it daily, right? But just on a personal scale, it's just it's a humbling and really unusual time for a number of people, right? And so it requires us to step up in a way that, you know, we have to put our cape on. We have to put our cape on for those who don't have consistent value in the spaces where they enter. So I am very grateful today to have Jill Cisco with us today and to share her story and stories of as a patient advocate. Thank you so much for joining us. Elizabeth McNeil from CMA. Coming from AMA, I'm very excited that you joined us today. Thank you so much for your candid conversation. And as always, Dr. Pucker and the NMQF family, you all have been doing a phenomenal job just keeping these conversations at the forefront and reminding us of what the moment calls for now and beyond. So thank you so much. Once again, I'm Mia Keys. I'm with the American Medical Association Center for Health Equity. And thank you for tuning in all. And tell your friends to join us again next week and stay well. I'll pass it back over to Brandon Garrett.
Thanks, Mia.
All right. Well, that was a very lively discussion. I really appreciate you all being on it. And I think we talked about a little bit of making sure that we're all active and participating. So 1, make sure everybody's done your census form. Make sure you're counted. 2, make sure you vote. And 3, make sure you participate and are active. So ways of being active, we have folks protesting out right there. They're writing their senators, they're writing their local leaders. And then this is also an opportunity for you out there, whether you're a physician or a patient advocate or have an opinion on this surprise medical billing issue, go ahead and reach out to your members of Congress as well. Just let everybody know your opinion. Let them know what you want to see happen. You have a voice, and you should go out and use it. And so that's what I got most out of this conversation. I hope you got something of value as well. Have a good day, folks.
Thank you. Thanks.
Thanks, everyone.
Thanks.